Coming to the genetic variants of mantle cell lymphoma, again, it's critical that I highlight p53. And now I want to, because we're talking about genetic variants, take a moment just to say that 17p deletion and p53 mutation are not the same thing. And it really seems that p53 mutations are those players that behave worse. And that's important to keep in mind. We've been screening for many, many years for these p53 variants using FISH, or p53 mutations using FISH. And again, if you have to exercise some caution there. And so if you see, again, an entire 17p deletion, you're really missing, a good portion of chromosome 17. Those mantle cells may not behave as worse. In contrast, at least our interrogation of our data suggests that those with true p53 point mutations, frame shift mutations, those that really influence more specifically now the behavior of p53, independent of now large genomic losses on chromosome 17, those seem to be doing worse. Again, I don't want to speak definitively about our data set since this is more preliminary, but what we're seeing is that the point mutations and just mutations specifically involving p53 may be a worse player. Talking about other genomic subsets, when we think about mantle cell lymphoma, ATM is perhaps the most commonly mutated gene. It is interesting that while you can see some overlap with p53 mutations along with ATM, that at least by and large, these two seem to be discrete groups. And again, I should make sure I communicate that mantle cell can evolve over time to acquire p53 mutations, and so certainly an ATM mutated mantle cell lymphoma may go on to develop this. But what you're really hearing me say is that by and large, mantle cell lymphoma seems to be defined not just by cyclin D1 mutations, which again affecting cell cycle, but also by mutations which impair DNA damage response. And so the subclasses now of ATM and T53, or at least thinking about them in that context, makes a little bit more sense. In terms of other genomic subsets, I think that that's a harder call to make. There's some interesting data looking at specific classes of mutations, such as those involving non-canonical NF-kappa B and their impact on ibrutinib resistance. There's newer data from Dr. Tam's group looking at SWI/SNF mutations and their potential to impact ibrutinib venetoclax given together in combination in mantle cell lymphoma. And so I think there's a lot of emerging data asking, okay, how do we personalize therapy? But I think that's a slightly different question than what you're getting at, which is broadly, are there genomic subsets of mantle cell? And really, I think beyond, the p53s, which carry the worst outcome, we can't say too much more about it, except to say that probably the majority of our p53 will carry ATM mutations.
Well, probably the two big divisions in the molecular subtypes would be those patients that are SOX11 negative and mutated versus unmutated patients. So patients that are SOX11 negative and mutated tend to have a very indolent course. They tend to present with circulating cells and splenomegaly, and that would be a patient population in whom you might watch them for prolonged periods of time before treating versus the classical presentation of mantle cell lymphoma.